Welcome to the third segment in our series on tuberculosis, Diagnosing TB, Understanding Important Differences in IGRA Test Design. In this video, we will explore pre-analytical variables that have been reported in the literature and how they can affect test accuracy in IGRAs. These variables are blood volume, shaking of the blood collection tube, blood incubation delay and time, interfering substances, and low white cell count. The literature suggests that these variables are more likely to affect tests with in-tube cell stimulation, such as ELISA and CLIA. We will now focus on the effect of these variables in detail, specifically on the ELISA and ELISpot tests, as they have been studied more extensively than the CLIA test, which is a relatively new IGRA. Blood volume is important. In both the ELISpot and ELISA IGRAs, adequate blood volume is needed to obtain enough cells. However, when collecting blood for the ELISA where in-tube blood stimulation is done, optimal blood volume is needed for good antigen-cell interaction. There is no opportunity to correct for cell concentration, and variability in blood volume has been shown to affect the final interferon gamma result obtained. Shaking of the tube is also important. In the ELISA, when performing in-tube cell stimulation, adequate shaking disperses antigen throughout the blood to allow the antigen-cell interaction needed. However, shaking the blood too vigorously, according to some reports, may lead to nonspecific interferon gamma production and possible false positive test results. Blood incubation time and delay are the next important variables to consider. When the blood sample is drawn directly into the specialized antigen tubes used in the ELISA, cell stimulation starts immediately. However, delay in incubating under appropriate conditions, for example, while the sample is in transit to the lab, has been shown to negatively affect results. Some substances, such as steroids and biologic therapies like anti-tumor necrosis factor, suppress the immune response. Others, such as endotoxins, may cause nonspecific production of interferon gamma. As a result, interfering substances are also variables. Their presence in the sample during cell stimulation may lead to spurious results. Removing these substances from the cell environment may mitigate this issue. Lastly, white cell count, specifically T cells, matters. If a patient has a low white cell count, there may not be a high enough concentration of cells present to produce a measurable response in the assay. A false negative or an indeterminate result may occur in immunocompromised patients with specific disease states or on certain drugs if the cell number is insufficient. Controlling for the number of T cells during cell stimulation may mitigate this issue and improve test accuracy. The ELISpot format eliminates many of the pre-analytical variables that can affect the ELISA because cell stimulation is not performed in the blood collection tube. In the ELISpot, PBMCs are isolated from the whole blood sample at the beginning. This enriches the T cell population, which is the foundation of the test. After isolation, the cells are washed to remove residual serum and other potentially interfering substances, which could inhibit cell stimulation or interferon gamma release and negatively affect test results. The cells are then counted to ensure there is an adequate amount to perform the test and facilitate correction for variation in patient cell counts. Next, cell dilution. This process standardizes the number of cells added to each assay well, ensuring that the required number are plated for antigen stimulation to produce a reportable result. The steps in the ELISpot, resulting in the use of a purified, standardized number of T cells, is a main differentiating feature between it and both the ELISA and CLIA. These steps result in accuracy across patient populations, including those considered immunocompromised. It's important to remember that all IGRAs are live T cell assays, and the integrity of the T cell population matters. The goal of all TB testing is to protect the patient and the wider community from a deadly risk. In 2018, the United Nations held its first ever high-level meeting on TB. At this historic meeting, 120 countries committed to work together toward the goal of eliminating TB by 2030. Early diagnosis and treatment of TB is paramount to reaching this goal, and healthcare providers are key in the fight to end TB. Because IGRA testing is globally recommended for the diagnosis of latent TB, education on the differences in IGRA test formats will help healthcare providers make informed decisions for their patients, helping to eradicate this deadly disease. If you have any questions or would like more information on the diagnosis of tuberculosis, please contact Oxford Immunotech Medical Education at ondemandeducation@oxfordimmunotech.com.